Welcome to the University of Dundee Orthopaedic Clinical Skills video for examination of the spine. Upon entering the room, introduce yourself and confirm the patient's name and date of birth. Explain what the exam involves and confirm the patient's consent. Ask if the patient has any pain in their back before starting. It is important to wash your hands thoroughly to prevent the spread of infection. Begin the examination with a thorough inspection. Removal of clothing above the waist is necessary for adequate exposure. Inspect the patient from behind. Look at the posture of the head, neck and shoulders. If the head is held to one side, this may be due to muscle spasm. Excessive flexion of the neck may be due to thoracic kyphosis. Causes for this include ankylosing spondylitis or thoracic vertebrae wedge fractures. From the side, look at the three normal curves of the spine: cervical lordosis, thoracic kyphosis, lumbar lordosis. Any deviation from this shape may be due to deformity or spasm. Note any focal angular deformities in the thoracic spine, known as a gibbous. There may be a visible curve in the coronal plane or asymmetry in the iliac crest height. As a scoliosis also has a rotational element to the deformity, there may be a prominence of the scapula on one side. Ask the patient to bend forward, as this will exaggerate any rotational deformity. Look for asymmetry in rib height. Now move on to palpation. Palpate the supraclavicular fossae for cervical ribs or enlarged lymph nodes. Feel the spinous processes from the cervical to lumbar vertebrae. Double check the coronal alignment for an unseen scoliosis and feel for a step due to spondylolisthesis. Palpate the paraspinal muscle bulk either side of the spinous processes. Assess muscle bulk and note any spasm. Assess the iliac crest heights. Palpate both sacroiliac joints for tenderness. Finally, examine chest expansion for restriction. This may be a subtle sign of ankylosing spondylitis. Now assess spinal range of movement. Consider this as the two separate segments with cervical and lumbar regions. The thoracic spine is anchored by the thorax and upper limbs and is relatively immobile. Begin with the cervical spine. Assess the patient while sitting or standing depending on your own height. Assess cervical flexion by asking patients to put chin to chest, then extension by asking them to lift their chin as far as possible. Cervical lateral rotation movements are best observed from above. Ask patients to look over each shoulder in turn. Compare each side. If necessary, placing your hands on each shoulder will improve accuracy by reducing thoracic rotation. Assess lateral flexion by asking the patient to try putting their ear to their shoulder. Compare left side to right. Watch out for compensatory shoulder movements in stiff cervical spines. Now move on to assessing range of movement in the lumbar spine. With the patient standing, perform Schober's test to assess flexion. Identify the level of the sacroiliac joints. Make a mark 10 cm above this level and 5 cm below. These two marks are 15 cm apart. Ask the patient to bend forward as far as possible. In a normally flexible lumbar spine, the distance between the marks will increase to at least 20 centimetres. Extension is assessed qualitatively. Look for stiffness on extension and ask the patient if they feel any discomfort. Finally, assess lateral flexion. Ask the patient to bend to each side and slide their hand down their leg as far as possible. Note the level they reach and compare the two sides. Remember that if the patient presents with any neurological symptoms, which may indicate spinal cord or nerve root pathology, this mechanical back examination should be followed with a neurological examination of the lower limbs. The examination is now complete. Thank the patient, help them with their clothing if required, and then explain any relevant examination findings. Ensure you wash your hands before leaving the examination room.